and thank you so much for joining us today for the webinar Guided Bone Regeneration Revisited, New Horizons Through Innovative Technology and Latest Materials. It is a great pleasure to introduce to you Dr. Önder Solakoglu, whose aim during this presentation will be to present an overview of conventional techniques for guided bone regeneration in dental implantology, as well as provide an update in new materials and latest technologies like CAD/CAM designed individualized block grafts and innovative methods in tissue engineering. Dr. Önder Solakoglu did his Master of Clinical Dentistry in Periodontology, MCD, at the University of London from 1998 to 2001. From 2001 to 2003, Fellowship in Oral and Maxillofacial Implants, Certificate Program at the University of North Carolina, Chapel Hill. 2004, Specialist für Parodontologie, DGP. From 2009, Diplomat of the American Board of Oral Implantology, ABOI, USA. We would like to thank Dr. Solakoglu for being with us today and botiss for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. Solakoglu at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Önder Solakoglu.
Thank you very much for this introduction, and good evening, dear colleagues, wherever you are and wherever you are listening and watching. It's a pleasure for me to do this webinar for ITI and botiss Academy on one of my favorite topics, the guided bone regeneration. And as you heard during the introduction, I'm originally born in Hamburg, and I spent some time in England and in the United States, and was working in a practice limited to periodontology and implantology in the USA, and came back to Germany in 2009 and started a practice limited to periodontology and implantology in Hamburg. And I also started the Seattle Study Club Hamburg, the Prophylaxis Study Club Hamburg, as well as the ITI Study Club Hamburg. And therefore, I'm in great contact with wonderful colleagues in my surroundings, and we are discussing and talking about interesting cases almost every day. Since my practice is limited to those two topics, periodontology and implantology, my patients are most of the time referred to me. About 90% of our patients were referred by colleagues. That means that we are working in an interdisciplinary team, and we share our thoughts and our treatment plan considerations with our colleagues. About 10% of the patients are patient-driven appointments. They found us during the internet or during other patients. So this is my great team, and as you all know in your practices, you can't work without a great team. So I have to thank my whole team beforehand, because all the cases I will show you today or tonight will not be possible without my great team. So thank you very much in advance for that. A little overview about the topics I would like to present to you and hopefully discuss with you after this webinar are the differences between different bone grafting materials. We will go a little bit into the allograft, about the specifics of alloplastic materials, as well as xenograftic materials. All of you know all these materials and probably use most of them during their daily practices. However, in my opinion, there are some advantages or disadvantages in several situations from one material over the other materials. We will also talk a little bit about, from my point of view, innovative technology and latest materials in the field of bone regeneration. We will talk a little bit about the bone ring technique, about the bone builder, which is basically a CAD/CAM designed individualized block graft. We will talk about this in detail later on. I will also talk a little bit about the patient's own growth factors, the PRGF system, as well as the PRF membrane, the the patient's own fibrin membrane. We use this almost in every surgery, when we will also talk a little bit about different membranes, like the Jason membrane, as well as the mucoderm, and the indications or contraindications of those materials. And last but not least, I will share with you some of my histologic results. We do biopsies of most of our materials that we started using, and we compare this histologically with other results, and then we basically decide to use this material on a regular basis in our office. So when we talk about bone grafting materials, we all know that we look for different properties of these bone grafting materials. One of the most important property, of course, is the osteogenic property, the bone growth, that we all expect to happen after our bone augmentation procedure. Of course, we also favor materials that have some biological properties, like osteoinduction, for example, for stimulation or differentiation of bone cells, like osteoblasts or maybe even osteoclast activation in some instances. And we also want our bone grafting material to be osteoconductive, basically to provide a three-dimensional matrix for our bone growing cells to grow into this material, and also the blood cells to form basically new bone. And ideally we want our scallop, our three-dimensional matrix, after a certain amount of time to be resorbed, so that we end up with living bone tissue. There are different materials or different matrices discussed already in the literature. There are also a little bit of work done about so-called bone morphogenetic proteins. You all heard about them. The indications, the contraindications, the risks involved in that, as well as research in stem cells. And I think there's a lot of potential in those research, and we will probably all benefit from that during our careers within the next few years, probably. So this is an example of a scallop, and as you can see here, we have lots of holes in it, and the structure allows the cells basically to grow into this matrix to form new bone. This is an overview about different materials that we all use in our practices. So the first and still the gold standard is the autograft, the autogenous bone, which is harvested either intraorally or extraorally. Then we have the material of the allografts, which is of human origin. And this one of these materials, the MaxGraft, I will show and discuss tonight. The xenograftic materials, which originated from animals. They are bovine, equine, or porcine origin, and we all know these materials, and they are also very well described in the literature. Alloplastic materials are synthetic materials, and the widest use is basically the calcium phosphate, the ceramics, the polymers. We all know those materials, and we will also talk a little bit about the advantages and the disadvantages of those materials tonight. And an example for this material is, for example, MaxResorb or the MaxResorb Inject by the botiss company. We all look for the properties in our bone grafting materials, and we all want the perfect properties. And all of us know that the perfect properties, as shown here, are probably a myth. It's unfortunately a little bit unrealistic to have all the ideal properties. So we have to look into the case, and we have to look into the indications or the contraindications that we have in this specific situation, and then we might use the one material over the other material, or sometimes we even mix materials to have almost perfect properties. One of the gold standards in guided bone regeneration is basically autogenous bone, and if you need big amounts of autogenous bone, the harvesting from the iliac crest is a widely accepted technique. As you can see here, an extraoral donor site. However, it is not always nice and easy for the patient, because we have some described morbidity in the patients following bone harvesting from the iliac crest, like in this publication from Stefan Lehndeckel. He described in 84% of his patients pain at the donor site. At 64% of the patients, they described a decreased functionality after 4 to 6 weeks or 8 weeks post-operatively. Almost 1/3 of the patients complained about a permanent defect of contour at the donor sites, and 7.4% of the patients had permanent defect of contour that was even visible. And about 4% of the patients complained about persisting pain at the donor site after the bone harvesting. With this in mind, we should rethink the iliac crest as the ideal donor site for autogenous bone. Since we have new horizons and we have new materials and we have new techniques, I think we should look back into our different abilities in guided bone regeneration and start from the beginning. Because the socket preservation, I think, is one very easy technique to have great result and easiness in implant dentistry. This is an example for an extraction without the technique of a socket preservation. So you can see the X-ray here, which shows the surgical site about 4 months after extraction, and you can see the significant bony defect. This is the same patient clinically, and you can see that this defect clinically looks even bigger than on the two-dimensional radiograph. There's almost no bone fill, and there's no way to insert an implant in an ideal prosthodontic ideal situation. So I don't think we should do this. We should rethink this, and we should maybe use a very easy technique using a bone grafting material or autogenous bone and bone grafting material covered by a slow resolvable collagen membrane, which is the Jason membrane in this situation. And we should cover the site and wait for about 4 months of healing. And this is the post-operative radiograph, and you can see great bone situation on this 2-dimensionally. And the clinical view 3-dimensionally shows that this bone grafting material, in this case it's an allograft mixed with autogenous bone, is converted into viable bone. It's basically the patient's own bone, and we can place an implant in a 3-dimensional ideal position in this situation. And this is the situation beforehand and this afterwards. And this is the post-operative radiograph. With this technique of bone preservation during extraction, we can basically avoid an additional procedure of a bone grafting procedure for the patient. So a few months later, we have the final result after uncovering of the implant and the final prosthetic situation. And this is the final X-ray. And this is the clinical view. And you can see that there are excellent hard tissue and soft tissue situations around this implant. So we could basically summarize that the socket preservation techniques during the extraction of the tooth gives us basically a stability of bone volume, is the basis for the soft tissue management, and in most instances, especially if you extract a tooth after a huge infection, in most instances it's the prerequisite for an ideal 3-dimensional implant placement. And of course, for optimal aesthetic and functional results as our patients expect from us. And we can also, as I mentioned before, avoid an additional separate procedure of a bone augmentation. So this is basically what I think we should consider in our offices as a very, very basic technique for guided bone regeneration. So I've looked for a case where I can show you different techniques of lateral and horizontal alveolar bone augmentation, and also, ideally, different materials used for that. A few years ago, we started with the Stallman 8 case. And this is the case I would like to present to you tonight. This is the initial view, and as you can see here, we have a very, very atrophic maxilla in this situation, as you can appreciate on the radiograph. We see that the sinuses are huge, that there's almost no bone height below the sinuses, and no way to insert implants in the maxilla at this point of view. So this is the three-dimensional analysis of the situation, and we manufactured a diagnostic wax-up before that, so you can see the diagnostic wax-up in relation to the actual bone level. And you can see here that the bone is extremely thin, extremely atrophic. And we look further back, then we can see that the sinuses are huge. There's almost no bone height below the sinuses. And in this situation, it's not possible to insert any implants at all. So this was the initial treatment plan for the maxillary right side. We wanted to graft the bone with the max graft, with an allograft material, cover it with a Jason membrane, and of course use the PRF membrane. The treatment of the maxillary left side was planned with the Max Resorb Inject, which is an alloplastic material, Cerabone, a xenograft, and the Jason membrane, the PRF membrane, as well as the Mucoderm matrix and fixation pins in order to increase the thickness of the gingival tissues. The treatment of the mandibular left side was planned with the use of Cerabone, which is a xenograft, Max graft as an allograft, Mucoderm matrix to increase the thickness of the tissues, a Jason membrane, a slow resorbable collagen membrane, as well as the PRF fibrin membrane and fixation pins. The treatment of the mandibular right side was planned using the bone ring technique in combination with Max graft, Mucoderm matrix, Jason membrane, and the PRF membrane. So this is a short overview about the different materials I will show you later on. This is the Cerabone, which is a xenograft. And Cerabone is a natural bovine bone grafting material, and it enables a fast integration of new bone formation. It provides a long-term three-dimensional graft stability, as we all know, has no foreign body or inflammatory reaction, and a rough surface for optimal cell adhesion and blood resorption, and of course it's a safe and sterile and easy handling. So this is an electronic microscopic view of this material with all its properties. And this is basically the product specifications. The granules come in different sizes and different volumes. The Max graft is a bone allograft material, and Max graft is a mineralized natural collagen human bone grafting material which is harvested from living donors. It enables complete tissue remodeling within 6 to 12 months, as we will see later on during histologic evaluation, and it has no antigenicity, is safe, sterile, and has also very easy handling. And it comes as granules as well as blocks, and we will also look at the blocks later on, which are fabricated individually for the individual patients, and that's called bone builder. The Max Resorb Inject is an alloplastic material. It's a non-hardening bone paste. It's injectable. It's 100% synthetic and completely resorbable. Basically, its composition is made out of 60% hydroxyapatite and about 40% beta tricalcium phosphate. So we can see the delivery system here, which is very nice and very easy handling. And this is the biologic activity of this material and its resorption rate with the slow resorbable portion of hydroxyapatite and the fast resorption portion of beta tricalcium phosphate. The Jason membrane is also a xenograftic origin. It's basically a porcine pericardium membrane, and it also enables a long barrier function between the bone and the soft tissue, and it's a slow degradable collagen barrier membrane, and it's very volume stable for a prolonged period of time because it has its collagen cross-linkage. Quick vascularization is possible due to the three-dimensional natural structure of the pericardium membrane, and it's very, very easy to use and has a very nice application and manipulation. It comes in different sizes, as you can see here, and you can see the surface of the upper and the lower side, and you can see that tissue grows very, very nice and easy to this membrane. The mucoderm membrane is also a xenograftic membrane. It comes in different sizes, as you can see here, and it's made out of porcine dermis. It has a very slow degradation and integration time and allows for several months of integration. It comes in two different thicknesses between 1.2 millimeters and 1.7 millimeters, depending on the case and on the indication. It has also a quick vascularization because it has a three-dimensional fiber network and enables even soft tissue replacement and mucogingival surgery, in some cases even without harvesting an autograft. It's also very easy to apply and manipulate, as you can see later on during the cases. It comes in three different sizes and it's very easy to handle. Let's go back to our case, and this is basically the initial view of our Stallman 8 patient, and you can see here how thin the bone is originally. This is the lateral window of the sinus lift, and you can also appreciate the hugeness of the sinus in this situation. And this is the Jason membrane, which I always use in order to protect the Schneiderian membrane. And this yellow fluid here is the third phase of the PRGF system. We always soak this membrane with the patient's own growth factors. And this is the application of the membrane in the sinuses. And as you can see here, it keeps the sinus open and provides for a nice and easy space to fill. In this case, with Max Resorb Inject, an alloplastic material. And this is how it looks after we filled it with this material. And now we do the lateral ridge augmentation using this mucoderm membrane that we soak first in combination with the mixture of our bone grafting material. So the membrane is fixed with the fixation pins, and then we use the open space to basically fill in our bone grafting material. And we use two of those membranes in this case, and we cover them with the collagen membrane with the Jason membrane. And then we try to reach primary wound closure, as you can see here. This is the initial view of the lower jaw left side, and you can appreciate how thin the bone is on this side as well. We used a similar technique. Here you can see the two membranes. We fixed the membranes with fixation pins, filled the space, and achieved primary closure with this continuous suture. This is the initial X-ray, the panoramic view, as you can see here. And this is the X-ray after the first bone augmentation in the maxillary left and right sinuses, as well as the ridge augmentation. as well as the lower left side, as you can see here. After about 4 to 6 months of healing, we planned for the implant placement in the maxilla. And these are the three-dimensional x-rays and the slices and the implant placements plannings, as you can see here. We planned for 6 implants in the maxilla and originally for 3 temporary implants in order to hold the removable partial denture. This is the clinical view of the implant placement in the maxillary arch, and you can see here the grafted maxillary arch. And compared to the initial view, you can see that we grafted a lot of bone width during this treatment procedures. This is the surgical stent fixed with osteosynthetic screws on the maxilla in order to provide movement of the stent. And then we used the normal Stallman protocol for guided surgery and inserted 6 implants in the maxillary arch. And you can see here 2 temporary implants. The temporary implant which was planned in the anterior maxilla was removed because we couldn't get it primary stable, but the 2 temporary implants were enough to provide stability for the intermediate denture. Again, the initial view, the view after the bone augmentation procedure, and the view after implant placement of 6 implants in the maxillary arch. Now we plan for the implant placement in the mandible arch using again Co-Diagnostics software. You can see here the nerve, the mandibular nerve canal, and you can also appreciate the reduced length of the implant placed in this situation. You can see this here and here, the occlusal view. That's why we decided to use the bone ring technique in this area in order to increase the length of the implant. It's highly discussed nowadays if it's even necessary to use longer implants than 4 or 6 millimeters. However, the bone ring technique is a very nice and easy technique to use or have more bone height in order to place a longer implant. So this is basically the instruments that you use for that, and this is the technique that was described before. So you can use a trephine drill and you can use a plateau drill, and then you have to slice and cut the bone ring in order to make it fit to the individual situation, and then you place the implant at the same time. This was the clinical situation of the mandibular right side where we used the bone ring technique. So you can see the initial drill, and this is the trephine drill. And this is the result of the trephine drill because you want a good bed basically for your bone ring. This is the plateau drill that we used to reduce a little bit of bone. Of course, we harvested this bone and we used it later on for bone augmentation procedures. So this is basically the preparation of the bone ring, and as I said before, we did this case many years ago, and at that point in time the bone rings were not available for Stallman bone level implants. Nowadays they are available for the 3.3 and the 4.1 millimeter implant, and you don't have to increase the diameter of the bone ring anymore by hand. However, at that time we did this, of course, very carefully. And we were able to insert a bone level, Stallman bone level implant at that time in combination with the bone ring. This is again the third phase of the PRGF fluid of the patient's own growth factors. And now we connect the bone ring to the implant and insert the implant through the bone ring. This is how it looks like, and then we have a cover screw, and we reform the bone ring a little bit to make it easier to adapt. And then we graft the harvested autogenous bone in combination with the bone allograft around it and covered it with the resolvable, with a slow resolvable JSON membrane at this point in time. This is the post-operative radiograph, and you can appreciate the amount of bone height that we grafted with this bone ring technique. And this is the panoramic view, radiographic view after uncovering of all 9 implants in this situation. This is the clinical view, and you can see nice and thick tissues around the implants, as well as in the mandibular. The prosthodontic rehabilitation was done by my great colleague, Dr. Holger Peters, who is a prosthodontic specialist in Hamburg, and the master dental technician Jens Silberbauer. As you can see here, a great result, and thank you very much to those 2 great guys to do this basically Stallman 8 case more or less for free. This is the final view, as you can see here, and the lateral view, the upper and of the lower jaw. And the patient was very happy. It was the first time in her life that she had a more or less stable situation in her upper jaw and no pain. And this is the situation of the lower jaw, fixed crowns and bridges, as you can see here. And this is the view of the primary telescopic crowns in the upper jaw. Yeah, very nice and very healthy tissues around it. And this is the occlusion view, and I think it's a great prosthodontic work. And this is the view of the denture itself. And as I said, the patient was extremely happy about it. And this is the final panoramic radiograph with the augmented bone in all 4 quadrants using basically 4 different techniques and different materials. And you can see here the individual x-rays, and you can see the great bone levels around the implants. Again, the initial view, that's where we came from, and the final result. As I mentioned before, we did, in order to document this case very well, biopsies. And those biopsies were evaluated histologically, as you can see here, the maxillary left and right side and the mandibular left and right side. And you can see here the differences, the allograft material which was used on the right side and the alloplastic material which was used in the left side of the maxilla, and the xenograft which was used on the left side on the mandible. All materials work very well in this certain indications. However, in some areas you can see more remnants of the bone grafting materials compared to others. Let's come to the very fascinating technique of the MaxGraft Bone Builder, which is basically an individually designed CAD/CAM allograft block graft. And this is the case where we decided to do this technique on. This is the 3-dimensional analysis of this case, and you can appreciate here a bone width between 2.8 and 3.3 millimeters, so not even enough bone to place implants primary stable. And using the DICOM data from the 3-dimensional DVT analysis, we have this planning model. And on this planning model, basically we virtually placed the implants in an ideal prosthodontic position. And then we knew how much bone was missing, and this is basically the size of the bone graft that we wanted. This is the lateral view where we can see basically the missing bone, and we can see the dimensions of the planned block graft, even in relation to the lateral crowns. So in a situation like this, where you've got a very, very atrophic mandible and you need to graft bone width and bone height, this technique of the bone builder is very easy and a very nice technique because, as I said before, it's individually milled, and the fit of this block graft is perfect, and gives you very, very nice adaptation, and of course also a very, very good healing. So this is the case, this was planned for this individual patient, and you can see here the dimensions of the block from different angles. This is the occlusal view. You can see how high and how thick and how big this planned bone block is. This again is the clinical view, and you can also see the very, very thin bone in this area, and this is the individually designed block graft for this individual patient. So we have looked at the surgery. We can see the easy handling of this material after lifting a mucoperiosteal flap carefully. We have a look at the bone tissue, and because it looks extremely thin here. And then we can have a look at the individual designed block graft, and we will have a try-in. And as you can see, it fits very, very well. So this was the first try-in that we had. And you can also see that it's dry. I always like to have this block graft dry as long as I can, because once it's wetted, it becomes a little unstable and it's not as easy to handle. So we do the drilling outside of the mouth, the initial drilling for the fixation screws, and then we bring it in position again, and then we mark the area for our fixation screws. I can move a little forward here. So you can see here we do just a little indication of the fixation screws position, and then without the graft we do our drillings with lots of cooling solution here intraoperatively. And then once that's done, we check the positions of the holes again. We do our cortical perforations in order to allow the ingrowth of blood vessels. And then, as you can see here, the fixation of the block graft. Move a little forward here. And this is almost real time, so we are about 3.5 minutes now. Basically, in the surgery, we are probably between 5 to 10 minutes at this point in time. And this is the third phase of the PRGF system. And now, once the block is basically fixed, we will rehydrate the block with this material. Then we will also harvest a little bit autogenous bone from the mandible and mix it with our bone allograft material. And then we will graft the bone a little bit around our block. Then the block is smoothened a little bit, and we will do our bone grafting around the block, and then we will cover it with Mucosa membrane, which is there in place already. It's very important to take the time during this procedure, because we need the contours to be smoothened, and we need basically the missing parts filled with this bone grafting granules mixed with this autogenous bone. And you can also see the easy handling of this very thin Mucosa membrane, which, as I said before, it's a pericardium membrane, and it's a very slow degradable membrane, so it gives you a barrier for a long period of time. And again, the third phase of the PRGF system. And before we finish our horizontal mattress suture, we bring in a little fibrin membrane of the PRF system, as you can see here. And we just move it underneath the suture before we suture everything back in place. Again, with the number of horizontal mattress sutures combined with continuous suture, as you can see here. Primary closure and, of course, keeping the primary closure during the healing phase is, as you all know, one of the most important parts. So you can see here the mobilization of the tissue and allowance for a secure primary closure is one of the most important things using this technique. And this is the situation immediately post-operatively. You can see this here, the clinical view after achieving primary closure. And again, the comparison to the initial situation and the situation after the block graft. Using the PRGF is, from my point of view, a very, very nice and easy addition to all these bone grafting techniques. We harvest a little bit of the patient's own blood. It will be centrifuged, and using those valves here, you can use them for the PRF fibrin membrane, as you can see on the right side. And then we will harvest the patient's own growth factors and mix it with the bone grafting material. So these are basically the PRF fibrin membranes in the expression kit. And with the expression kit, you can reach a very nice, very homogeneous, very thin body's own fibrin membrane in order to cover the surgical site and the collagen membrane. This is the post-operative radiograph of the block. And this is the clinical situation after 6 months of healing. You can see a very healthy tissue and very nice and thick bone. The 3D analysis before placement of the implants, you can see here, and you can see the fixation screw here, and you can see that there's no gap in between the original bone and the block graft. The graft was healed very nicely, and it was remodeled in the patient's own bone, basically. So this is the planning with the radiographic stent in place. And this is the implant planning using, again, co-diagnostic software for the 3 implants. And you can see here the position of one implant here, covered by the block graft harvested bone. And here you can see the second implant in place before the surgery, of course, and then the planning of the position of the third implant. So this situation beforehand, you can see the situation now, and this is the clinical situation. And you can appreciate living bone tissue. You can see it's very nicely supplied by blood vessels, and it's very stable, and it's almost impossible to distinguish between the original bone and the grafted bone. Again, to compare the initial view before the block graft technique. Then, of course, we removed the fixation screws and prepared for the implants. And you can again appreciate the nice vascularization of this bone block. You can see the bleeding, and it's very fresh and very nice bone tissue. And this is the situation after placement of the implant, and of course, again, achieving primary closure. This is the immediate post-operative radiograph of this case compared to the planning. We were able to place the implants in the exact planned situation, and this is after 4 months of healing, 4 months post-operatively, and this was just a few weeks ago after uncovering of the implants. So as a summary, you can say that basically the technique of Maxgraf Bone Builder is very nice for extensive bone defects and atrophic maxillar and mandibular arches. You can use it for horizontal and vertical bone augmentation procedures. And the benefits of this digital planning and digital augmentation procedure is basically that you have an individualized, very well-fitting block graft without harvesting site, without a donor site. Very nice wound healing, a very simple procedure, very reduced operation time, which is very good for your patients. And this is the workflow. First of all, you need the DICOM data, and then you will have a three-dimensional design, which you discuss with the company. And once you give your okay, the block graft is basically produced, sterilized, and then delivered after approximately 4 to 6 weeks to the clinical user, and then you can use this. So you can see the technique of this so-called free-form modeling system, which is a very fancy program that you can use to graft this individual site or plan this individual block. And then after that's done, it will be sent to you as a 3D PDF file, and you can have a look from every angle, and even with crowns, with implants, without the surrounding bone, with the surrounding bone, and then you can give your okay, or you can have some modifications done, and then basically once it's agreed on, it will be fabricated, will be milled. One of the milling centers, you can see here how it's done. The block is basically placed in this milling machine, which is programmed, and then it's cut to this individual size. And after this was milled, it will be packed, sterile, and then it will be mailed to you. And this all is, of course, done under clean room conditions, as you can see here. So this basically allows for really, really good adaptation in this individual site. So this is basically the overview of the donor tissue network, which is done here in Europe. And basically all the materials of this particular technique, of this allograft bone, are from living donors. And this is some of the tests, some of the incoming inspections. Then the processing of this donor tissue is very long and very good documented procedure with ultrasonic cleaning and the diethyl ether and ethanol cleaning, the oxidative treatment, the lyophilization, and then finally a gamma irradiation, even to destroy potential DNA. So, as I said before, before we use a new material in our office, we always do our own histologic evaluations. So that's what we also did with this allograft material. We looked at different time points after implantation of these materials, after 4, 6, 9, and 12 months. And we had to look at the healing of this on a histological level. So we took the biopsy, and it was analyzed at a laboratory in Hanover with Mrs. Cousins. She was a student of Professor Donat, and she used the technique described by Professor Donat. So you can see this here at 10 times magnification. You can also appreciate the allograft materials. You can see newly formed bone in between. This is the 20 times magnification. And even higher magnification, you can see still particles of the allograft and new bone formation within the allograft, and of course connective tissue. The higher magnification even shows osteoclastic activity. Here you can appreciate the lagoon, which is caused by an osteoclast that is basically eating this bone grafting material. And on the other side, you have osteoblastic activity of newly bone formation. So this is basically the result by Professor Maschek. He's a pathohistologist in Hanover, and he found still some avital bone particles, very little amounts, but he still found them. Newly formed osteocytes, rich bone along the outer surface of the bone matrices, small pieces of avital bone, most likely the allograft material, and loose connective tissue surrounding this newly formed bone, and new bone formation about 80% after 4 to 9 months of healing. And he summarized the increasement of bone building in the time frame between 4 months and 12 months after augmentation, and no signs of inflammation. So, coming to the end of this presentation, I will provide you, of course, with the little take-home message. And this is this little message what old people do for fun here in Germany. So be careful if you're driving. So, my dear colleagues, as you can see, life is not always plannable, but from my point of view, guided bone regeneration is. And with this, I would like to thank you very, very much for your attention. And I'm looking very much forward to a nice discussion with you. So thank you again, and wish you a very nice evening. So I hope that some of you typed some questions in already, so that we will have a little discussion here. All the techniques and materials I showed in my presentation today are, from my point of view, materials that you can easily use in the daily practice. Techniques that are easy to learn, and not only for the surgeon, but also for the whole team, which is very important, because as you all know, it's very, very significant that your team is also familiar with all the situations and the materials and know how to handle that. So I cannot see any questions at this point of time. Maybe it takes a little while to type in those questions. If you think about questions later on, hello.
Hello.
You can also.
We do have a lot of questions.
We do.
Can you please go back to the questions and answers box?
Yeah, I think that's where I am right now.
Okay.
I cannot see any questions, actually.
One second, please. Can you switch to the presenter view, please?
Yes, that's what I did right now, and I don't see any questions. It's no, unfortunately not. Maybe you can read the questions to me.
Okay, so okay, so first question is how mobilize the mucoperiosteal flap in order to cover all these materials?
Okay, that's a very good question. Did the participants hear the questions?
Yes, I think so. Can anyone just confirm, please? Thanks.
Okay. Well, this is a very important question, and it's very crucial for the result. So one very important part to evaluate beforehand is the thickness of the tissue. And if you are not sure that you have enough tissue thickness, then you would need to increase the thickness of the biotype of the gingival tissue beforehand. And a very nice material to do this with is, for example, Mucoderm. So this would be a procedure that you need to do beforehand. And then afterwards, I always use a periosteal cut to mobilize the tissue in order to achieve primary closure.
Okay, next question.
Yeah.
In these cases, is there any difference between using resolvable or non-resolvable membrane in terms of treatment outcomes?
That's also a very good question. Probably, technically spoken, is not a big difference because the membranes, the resolvable membranes that I use, they have a very slow degradation time. So they stay there for a very long period of time. And the long period of time is basically 4 to 6 months, which I think is sufficient. I don't need a membrane that stays longer than 4 to 6 months. However, if you use a membrane that is a non-resolvable membrane, and there are very good membranes available, as we all know, you have to remove them, of course, and you have a little higher risk of technical problems. Membrane exposure, for example, is one of those. Infection of the membrane is another potential problem. So from my point of view, I'm a very happy user of slow degradable resorbable membranes.
And the next question is, how long you have to wait to put the crown over implant with bone ring techniques?
Oh, I usually wait for the normal period of time, which is about 4 to 6 months. I always wait for my bone to heal 4 to 6 months, and then I uncover the implant, wait for another week, and then the crown can be placed.
Thank you, and here comes the next one. What is the difference between Mucoderm and Alloderm, and uses of each of them?
To be honest, I'm not very experienced with Alloderm. I've used it several times when I was working in the US. And my results were similar to the results that I have with Mucoderm. I think the indication of Mucoderm in my practice is basically the mucogingival surgery in order to increase the thickness of the gingiva. But I also use it for covering of recession defects, but only in that instance where you have enough keratinized tissue and you can cover the mucoderm. This is, from my point of view, very crucial, that you can cover the mucoderm and you have basically primary closure. If you don't, I would always use autogenous graft.
Thank you, and here comes the next one. What is the software you use for these plant bone grafts?
Once more, please. I did not hear this question.
What is the software you use for these plant bone grafts?
For well, there is basically not a specific software that I use for planning this bone graft, because this block graft is planned by the company botiss. So what you basically as a user need to do is to provide them with DICOM data, and you can upload the DICOM data on the website. And the software which is used is this freeform software, but I don't think that you need to use it in office. So it's provided by the company, and you get the 3D PDF file, and you can check if it's according to your expectations, and then they can still modify it if necessary.
Okay, thank you. And here comes the next. Why did you use only bone level implants in your cases? And do you find any variety in success between Stallman tissue level and bone level implants in grafted sites?
Very good question. To be honest, I don't see any differences in longevity or in stability between the bone level and the tissue level implants. Since I am referring based office, as I mentioned before, I always talk to my referring colleagues, and I ask them what kind of preferences they have. I don't do any switching of companies and using implants. I'm not very fond of. However, I use bone level implants as well as tissue level implants, but most of the time I let the prosthodontic dentist make the decision, because I think in some instances it's easier to restore and gives also a very nice aesthetic result if you use bone level implants. And I also like to have the option of primary closure that in some instances with tissue level implants you don't have. So if I use tissue level implants in grafted sites, sometimes I graft at the time of implant placement again, the second time, and then I have the freedom of achieving primary closure very easily. But that's a very good question, thanks.
Okay, thank you. And here comes the next one. Did that block graft remodel into laminar bone or cancellous bone?
Well, this block graft is has a very, very thin layer of cortical bone. So this is basically why you should be a little careful during the placement of this block graft. And it will remodel into cancellous bone, and sometimes you can even see an increase of thickness of the cortical layer on the three-dimensional X-ray. But I don't think not much.
Thank you. And we go on with the next one. Is possible use bone ring techniques with soft tissue implants?
I'm not sure if I understood this question. Can you repeat
Yes.
it, please?
Is it possible to use bone ring techniques with soft tissue implants?
With soft tissue implants. So, well,
That's what it says.
well, I'm not sure I understand the question correctly, but I think to increase the height of the soft tissues, I think, yeah, why not? But that would not be my preference, to be honest.
Okay, next one. Centrifugal protocol to obtain PRF and PRGF, the difference.
Well, there are very different protocols, and it always depends on the centrifuge you have. So I think the easiest way to obtain the correct protocol is to contact the individual company and discuss with them in order which centrifuge you have, because there are so many different times and speeds that you can use, so that you really have to make sure that you have the right protocol for your centrifuge. And we tried it many times, and now we have the correct protocol, and it's about 8 minutes of centrifuging and at 540 G. But this is very specific for our centrifuge.
Okay, thank you for your answer. And there's another question which says, is there any edema after the operation and how do you face it?
Well, I think most of the time you have some edema after surgical interventions. However, this, as I showed you, is a very quick and easy procedure, so the surgical edema is very limited. You can consider the use of some medication in order to reduce this edema. However, we don't do that. Usually I just instruct my patient to use a cooling pad for 24 hours or 48 hours and reduce any trauma. This should be sufficient in most cases. I think we have some time for 2 more questions, so if you have more questions, I'm happy to answer them.
Okay, so and here comes the next one. What is the arbitrary cost of such bone block?
Oh, it varies, but I think the estimate is about 1,000 to 1,200 euros approximately.
Okay, and here comes the last one. What kind of PRGF system is used?
The PRGF system that I use is the BTI system. And the PRF fibrin membrane system that I use is the botiss system.
Okay, so thank you for your answer, and I'm about to leave now. I don't want to take this any longer. I'm pretty sorry that we had this little issue with the questions, but I hope I could help a little bit out, and hope to see you next time. Thank you.
Thank you. Thank you so much. Good.